Okay, great. So I think we'll get started. So welcome everyone to the AHNS virtual education series. Tonight we're talking about HPV liquid biopsy, and what we're going to try and focus on is largely on the ethical and practical considerations. So we're not going to talk a lot about the science, which is certainly more common topic for me and probably for many people, but more on some practical and ethical considerations. And so I want to start by having our moderators and panelists introduce themselves, and we'll also go through our disclosures. Here's our group tonight, and if we could maybe start with Andy, do you want to introduce yourself?
Sure. Good evening, everyone. My name is Andy Schumann. I'm an associate professor at the University of Michigan and the Ann Arbor VA, and I have no disclosures that are relevant, although my university does have some patents and grant funding related to the topics at hand, none of which have financial implications for me at all. Thank you.
Chiara?
So thank you. Good evening, everyone. I'm Chiara Mannelli. I'm a bioethicist, and actually I'm a researcher in bioethics at the Italian Institute of Health. And I have no disclosures nor conflicts of interest.
And thank you for joining us in the middle of the night. Appreciate it.
My pleasure. Thank you to you.
Carol?
Hi, I'm Carol Fakhri. I'm at Johns Hopkins. I serve as professor, division chief, and associate dean of clinical affairs.
Dave?
Hello, I'm David Routman. I'm a radiation oncologist that focuses primarily on head and neck at Mayo Clinic. And those were my disclosures that were up that just went away. There we go. So I have some research and IP related to methylation markers, as well as clinical trials that are using a commercial assay, the NavDX. I have no royalties or COI, except that I'm participating in leading studies using that assay.
Great. And I'm Dan Faden. I'm a head and neck cancer surgeon at Mass Eye and assistant professor in Department of Otolaryngology at Harvard Medical School. My relevant disclosures are that I do work in the liquid biopsy space. I get funding from a number of different companies who make ctDNA-based assays. I do consulting work for companies who advise on liquid biopsy work, and I have patents and pending patents in the space. So you're going to talk a bit about our learning objectives over the next 50 minutes or so. And can you guys see my slides okay? On my screen, they're off a little bit, but can you see the full slide? Okay, great. So we're going to discuss HPV liquid biopsy testing, some of the current limitations, and how these limitations can confound interpretation. We're going to talk about understanding the complex ethical dilemmas which can arise from utilizing new diagnostic assays in general without standardized approaches. And we'll talk about the impact of false negative and false positive results on patient care and well-being. So I'm going to start by giving a very, very brief background on ctDNA and ctHPV DNA, just to try and make sure we're all on the same page. And then we're going to talk about some ethical issues, some background information on ethical issues. I'll present some cases to the panel to talk about some different scenarios and how what we may encounter or are encountering, and how it potentially impacts patients and physicians. And then we'll have time for Q&A. So to get started on a background on ctDNA, and sorry, I'm going to ask you again, you guys can see the full slide because on mine is cut off. Okay, perfect. Awesome. I trust you. So I'm going to talk a bit about ctDNA. So I'm just going to very briefly cover methods of ctDNA detection. I'm going to talk very briefly about what we know about ctHPV DNA at the time of diagnosis, during or immediately after treatment, so adaptive treatment, in the adaptive treatment setting or minimal residual disease, MRD setting, talk a bit about monitoring, and then some ongoing studies. So all cells release fragments of double-stranded DNA. This is called cell-free DNA. And when it comes from a tumor cell, we call it circulating tumor DNA, ctDNA. And virally mediated cancers also release fragments of the viral genome, So in the case of HPV, people typically refer to that as CT-HPV DNA. And what you have is really a needle in a haystack kind of problem, because you have much more total cell-free DNA than you do ctDNA. And so you need very specialized approaches to be able to reliably detect the ctDNA. And the two most common platforms that are utilized are something called droplet digital PCR, ddPCR, and next generation sequencing. And I'm going to talk very briefly about ddPCR because this is the platform that's used to generate most of the data you see in the literature right now, most of the data that I'm going to show tonight, as well as the most commonly utilized commercial assay. So ddPCR uses just standard PCR principles, except for that your sample is partitioned into many thousand droplets, about 20,000 droplets. And then the PCR reaction takes place inside each of the droplets. And if your target is present, it's amplified and a fluorescent, a reporter dye fluoresces, and that can be measured on a specialized machine. And the benefits of ddPCR is that it provides absolute quantification. So one positive signal means one piece of DNA was there, and has very high sensitivity and fidelity. So a number of different groups across the US and across the world have developed ddPCR-based assays. I listed just a few of them here. And these assays can come in different flavors. They can come as singleplexed or multiplexed. So they can detect one HPV genotype or a slew. These are the 5 genotypes, for example, that our multiplex assay goes after. And this is important to know because if your genotype's not in the assay, it's not going to be detected. And most of the readouts are in some form of copies or fragments per milliliter of plasma. There are also a number of NGS-based approaches, and we're not going to focus on those tonight because there's much less data in that space and they're less commonly utilized. There is one commercially available NGS-based assay that detects 2 HPV genotypes, and a number of research-based NGS assays, and I've listed a few of them here. So to look at the data that we have presently, and again, I'm going to do this very briefly. So this is not meant to be a comprehensive discussion of all the data in CT-HPV DNA, but just to get us on the same page, I'm going to talk about the time of diagnosis. So this is data from my group from one of the earlier studies we had done in 2021, looking at the diagnostic accuracy of a ddPCR-based assay at the time of diagnosis. You can see 70 cases and 70 controls, and very high sensitivity and specificity at the time of diagnosis. And in fact, when you compare this to standard of care, which is an FNA with P16 staining, it outperforms standard of care. This is a meta-analysis that we've done that's under review, not currently published, but soon to be. Looking at a number of different studies at the time of diagnosis, you can see the pooled sensitivity across those studies is about 90%, and the specificity 97%. So very specific and pretty decent sensitivity, but certainly not perfect. And so what this means is that about 1 out of 10 patients who you send a test on at the time of diagnosis are going to be negative, simply because the assay or the test you're utilizing isn't able to pick up the CT-HPV DNA. What about, and the data I was showing there is in HPV positive oropharynx cancers. So what about other HPV positive head and neck cancers? This is a study that my group did looking at HPV positive sinonasal and nasopharyngeal carcinomas, showing, again, very high performance metrics. And I apologize, I didn't put the sensitivity and specificity on the slide, but it was in this study, it was 100% for HPV positive sinonasal and nasopharyngeal carcinomas. So it works in that setting as well. Moving on to adaptive treatment space and minimal residual disease detection. There's been a number of studies in this space over the last couple of years. I'm showing just a few here. First, in chemoradiotherapy, this is one of the earlier studies from the UNC group, Bisham Shera and Gaurav Gupta, that looked at patients being treated with chemoradiotherapy. And what they essentially show in this study is that patients who clear their CT-HPV DNA earlier in treatment, here they use a 4-week cutoff with 95% clearance, these patients tend to do better than patients who don't clear early. And then this is a more recent study from 2023 from a Japanese group, Tanaka et al. That looked at radiation alone. So similar question, but now without the chemotherapy, just purely radiation with very similar findings. Early clearance, patients do better, have better overall survival. What about in the surgical setting and the MRD setting? This is a study from my group looking at early clearance kinetics after surgery, showing that CT-HPV DNA levels trend down and clear very quickly after surgery. So this is looking at blood draws every 6 hours after surgery, for example, showing that patients who have surgery, no adjuvant treatment, and go on not to have a recurrence. So we know their cancer is completely removed. Their levels clear very rapidly. So for example, postoperative day 1, which would be about 18 hours after surgery, their levels have already cleared. Patients with risk factors for macroscopic residual disease like gross extranodal extension, their levels stay very elevated. Based on this, we set cutoffs. We applied it to a much larger cohort of patients having surgery and found that this held true. Again, in blue up here are patients who had surgery, went on to observation without adjuvant treatment, did not recur. You can see they all clear their CT-HV DNA by 1 day after surgery. In red are patients with, again, macroscopic residual disease. They stay very elevated. This is a study by our very own David Routman here on the panel, looking again in the surgical setting at patients who have detectable or not detectable CT-HV DNA levels after surgery, showing worse survival if you have detectable levels. And in the monitoring settings where we probably have the most data right now, the largest studies, and I've listed just a few of the bigger studies, including a study, that actually came out literally a day or two ago in Clinical Cancer Research out of Copenhagen, looking at the performance metrics of detection in the monitoring setting. And what we know is that there's very high positive predictive value in the monitoring setting. So if you have positive levels, re-elevation of your levels, it's very predictive of recurrence. Relatively good negative predictive value when you look at multiple time points across time. There's a span of lead times, meaning the time between when a recurrence is detected molecularly and when it's clinically detected. But on average, when you look across these studies, the average lead times fall into the 3 to 4 month range for molecular detection to clinical detection. There's a number of ongoing prospective studies looking at CT-HV DNA using a slew of different assays. I've listed a number of them here, not all of them. The institutions they're being run out of, the settings they're being done in. You can see they're looking at multiple different settings, including chemoradiotherapy, surgery, neoadjuvant setting, recurrent metastatic. And so these are going to be really critical to look at how they read out in the coming years to really see better prospective data. Because as you likely can tell from the data I was showing, the data that we do have, I would summarize by saying it's highly promising. There's a lot of good early signals. There's a rapidly growing body of literature, but they're largely single institution studies. They're largely retrospective or observational, and thus they're very subject to different forms of bias and overfitting of the data, including the data I was showing from my lab. And right now, we really have no published prospective head-to-head comparisons with standard of care. So I'm going to pause there and hand it over to my colleagues to talk a bit about some of the ethical considerations in using new diagnostic tests. So Chiara, I believe you're going next.
Yep, just a sec. I'm gonna share my screen. Okay, can you see that? Okay, great. So hi everyone, thank you again for having me today. It's a great pleasure. So I will do my best to push everything in 5 minutes, but I do apologize in advance if I will take a bunch of seconds more. So I'm going to share some thoughts with you on the ethical framework of liquid biopsy performed through a blood draw for cancer detection. So we are going to talk about the gold standard in cancer detection, which is tissue biopsy, and about how liquid biopsy might offer an opportunity to overcome the barriers posed by tissue biopsy. And then we will discuss the advantages and limitations liquid biopsy offers within a specific focus on the ethical perspective. Tissue biopsy, what are the main limitations? It's time, feasibility of tissue retrieval, invasiveness, and incompleteness, as tissue biopsy may fail to account for tumor heterogeneity, and this may impact treatment success, with implication for the feeling of trust in the patient-physician relationship. Some of the barriers posed by tissue biopsy can be overcome by liquid biopsies. First of all, time, because liquid biopsies allow early detection of the tumor, feasibility of tissue retrieval as it involves a simple blood draw, invasiveness, as liquid biopsy represents a non-invasive procedure and can be repeatedly performed to monitor disease progression and adjust treatment paths, and incompleteness, as liquid biopsy may help to reveal tumor heterogeneity by providing repeated collection of ctDNA. Yet, despite its scientific potential, liquid biopsy poses ethical concerns and limitations. First of all, the occurrence of false negative results. Wrong diagnosis could lead to a delay in the therapeutic intervention, and moreover, patients with a negative response may feel safe in a certain sense and overlook preventive measures in the future. False positive results as well, caused by the high sensitivity, are closely related to the phenomenon of overdiagnosis and overtreatment, and may lead to an unnecessary costs for therapies and cause stress, risks, and anxiety for the patient. You know that being diagnosed with cancer has generally a deep impact on individuals, and thus it may be ethically concerning to expose individuals to such an emotional unsettlement when there is no certain clinical reason to. Both false negative and positives share implications from a narrow ethical perspective, as their occurrence might affect the physician-patient relationship by jeopardizing the feeling of trust towards both the physician and also the diagnostic tools professionals rely on. Clearly, the introduction of cancer diagnostic tests calls into question ethical concerns related to patients-informed choices. You know that the basic ethical premise of informed consent is that autonomous agents freely make decisions about medical procedures after considering risks, benefits, and available alternatives. This aspect leads to the need for an adequate communication between patients and physicians for a truly informed decision to be made. Yet the relevance of an adequate communication does not end with information and eventually consent to perform the procedure itself. Rather, communication is vital when it comes to manage results and follow up with shared decision making. Just to give you an idea, think about how challenging it might be for a physician to manage communication and share decision making concerning treatment with a patient who had a positive liquid biopsy test, but whose follow-up imaging tests are negative. Understanding such a discrepancy in results might not be immediate for a layperson, and it may confuse and disorient the patient. And this may lead to misconception, misunderstanding, and misestimation. This is true for liquid biopsy performed under medical supervision, but even more if we think about potential direct-to-consumer solutions. So such a scenario highlights the need for a standardized regulatory approach in order to apply the extraordinary potential of liquid biopsy for cancer detection and respect at the same time the rights of patients and physicians. Some take-home messages. Liquid biopsy offers great chances for cancer detection, of course, but it should be used after a careful risk-benefit evaluation. Improving and promoting support for patients-informed decisions is vital, and improved communication between patients and physicians is, in order to not to undermine trust, is central. And the last one, attention should be focused on the need for a regulatory standardized approach. Thank you.
Thanks. And I think Andy's going to go next.
That was fantastic, Yara. Thank you so much. I'm going to pull up my slides here as well. I just get a thumbs up that you can see that okay?
You got to switch your, there you go. You're good now.
Perfect, great. Thank you again for the pleasure to present tonight. For the next few minutes, I'm going to talk a little bit about both ethics and the regulatory landscape of liquid biopsies and how these apply to what we're talking about today. So I'll talk a little bit about research versus clinical care, then some different regulatory agencies and what their roles are in this field. and then open this up for the cases thereafter. So we all know intrinsically that when we enroll someone on a clinical trial, they switch from being a patient to a subject. But what that means in practice may be a bit different. Clinical care, as we know, is focused on the primacy of the individual patient's best interest. We do what's best for the patient in front of us. When we enroll patients on clinical research, though, especially on trial, we are making a hypothesis-driven guess of what might work and testing it in an experiment to create generalizable knowledge. What that means is that the research subject is not necessarily the focus of the intervention itself, but rather the generalizable knowledge that's created is the primary focus. Now, of course, that means we still have to protect the subject, but the underlying premise is different. That also means that regulation of clinical care and research are different. In clinical care, generally something bad has to happen in order for there to be a harm, but in research, simply breaching the protocol can create challenges both with funders as well as regulators. And we all know what this means in practice, which is that research is a lot harder to do than taking care of patients, at least from a regulatory standpoint. So when we get informed consent in clinical care, we're focusing on what's best for that person, risks, benefits, alternatives, all related to that individual patient. And there very well may be major risks that are acceptable because individual patients and doctors accept a certain degree of proportionality that's different than an entire slew of research subjects might, because it's focused on that one individual. Similarly, patients may not want to be a part of something, even if it's a minor risk, because of their own individual choice. And of course, that is a quality of life consideration they may choose. But the bottom line here is that the risk-benefit analysis of any clinical intervention is between that individual clinician and their patient. In research, however, the premise is different. We need equipoise. We need to know that something is reasonable to test in order for us to be able to make this judgment, not for an individual, but for all of the patients who are being enrolled in this trial, or whatever the intervention may be, because at the cohort level, the goal is to create generalizable knowledge. What this means is that the goals of informed consent in clinical care and research are different. One of the arguments and the relevance to what we'll talk about today is there's a conflation between clinical care and research vis-a-vis liquid biopsies, because very often, very well-meaning clinicians and researchers really think they're doing both at the same time, especially if we're not on a formal RCT protocol, but rather doing research within clinical care. And this will come up over the course of what we talk about. I'm going to transition and talk a little bit about the regulation of lab tests, which sounds kind of dry, but is important for what we'll cover, and I promise I'll do it quickly. So the FDA is a federal agency of HHS, an executive branch of the federal government, that protects and promotes public health by controlling and supervising food, medications, vaccines, and other stuff. That other stuff includes diagnostic testing. There's a specific category for each of these, and FDA clearly has jurisdiction to regulate diagnostic tests. They focus on safety, effectiveness, validity, and quality. And generally, for these tests, you need pre-market approval and surveillance to make sure that they work and they're safe. But there's a very large loophole, and we need to talk about that. An LDT, or a laboratory-developed test, is a separate category through FDA as an in vitro diagnostic assay that is diagnosed, manufactured, and used in one lab. Historically, these were, to use one example, the vitamin D test that your family doctor did in his back office in his lab, in the clinic. Generally, FDA has not scrutinized LDTs because they were considered low risk and they were so decentralized. And there's a concept of enforcement discretion within FDA, where basically they can choose what and how much they want to regulate and enforce something. As a result, FDA has chosen, or is not able to, or use your explanation of choice, not involved in pre-market review, clearance, authorization, or approval of LDTs. The vast majority of LDTs historically were pretty simple, but that has changed. LDTs now are much more complicated. They may reach across the country. Even if they're performed in one lab, they're done for patients all over the country. And they've not necessarily undergone pre-market review like other tests. And there are problems with this that FDA has recognized. For example, FDA published a piece talking about how they're concerned that people could initiate unnecessary treatment or delay or forgo treatment altogether for a health condition as a result of a faulty LDT. And they've called out specifically that cancer patients have been exposed to inappropriate therapies or not getting effective therapies because of the limitations of LDTs. So FDA has the ability to regulate these. And one example was 23andMe. 23andMe was marketing directly to consumers and misrepresenting what they were offering and doing in a way that basically got FDA to act. However, for the vast majority of LDTs, including lab-developed tests to test for cancer and cancer recurrence, there is that enforcement discretion. So in 2014, FDA had a draft guidance saying they might be doing more to enforce this. There was quite a bit of pushback. Short answer is nothing has changed in the regulation of LDTs over the course of the last decade or so. CMS is totally different. Now, this is an organization that regulates clinical labs and testing via CLIA, the Clinical Lab Improvement Amendment, totally separate from FDA. CLIA only requires that a test detect what it says it's going to detect. So, for example, you can design a test that says blood is red, and it will be CLIA certified if indeed your test shows that blood is red or the right shade of red. That's a silly example, but the point here is CLIA is only involved in making sure that you're measuring what you say you're measuring. They are not looking at clinical validity at all, and there's no assessment of how well the test can diagnose or predict any clinical condition whatsoever. So in order to get reimbursed, you need CLIA certification, but you don't necessarily need FDA authorization if you're an LDT. And payment is completely at the discretion of the insurer, so it is really necessary to have CLIA certification to bill, but the FDA may or may not have a hand in what that actually looks like in testing how well it works. Using Naveris as an example, NavDx is a CLIA certified test. It is billed both through commercial and government carriers with a new CPT code that just came out this year. By their data, they've estimated 20,000 claims in 22, and they expect that to go to 60,000 in 24. And their website calls this the first and only clinically validated circulating test for looking at HPV-driven cancer. It is absolutely true that this is approved and it is CLIA certified. However, you can make your own judgments about that clinical validity, given the fact that FDA was not necessarily a part of that process. So in short, clinical care and research are governed differently. FDA has oversight over diagnostic testing, but has quite a bit of enforcement discretion relevant to what we're talking about today. CLIA certification does not require an assessment of clinical validity, and the regulatory landscape is not currently designed or capable to deal with the morass of new testing, such as what we're talking about today. With that said, liquid biopsies can be clinically available and reimbursed without necessarily showing evidence of clinical value. And obviously, our goal over the next 26 minutes is to talk about what that means in practice. Thank you for your time.
Thanks, Andy. That was awesome information that I think is important for everyone to understand. So we're going to now launch into a discussion of cases, basically. And I'm going to ask the panelists to comment on these. There's going to be a lot of questions, so I would hope everyone participates. The audience cannot chime in, but they can enter questions into the chat. And so I would encourage people to do that. And maybe one of the other panelists can sort of monitor that and bring those to my attention as I'm presenting the cases if I don't see them. Okay, so here's our first patient. This is a 59-year-old male with a T2N1 HPV positive head and neck cancer treated with surgery. And this is what their ctHPV DNA graph looks like. You can see a negative value at day 200. So I'm going to open this up to the group, and I'm going to ask, how do you interpret this, this data point? What does this mean to you? Dave, I'm going to call you out because I know we talk all the time about this stuff.
So this data point can be a little bit hard to interpret because you do not know whether this patient had detectable ctHPV DNA prior to the time of surgery. So that could be a true negative or it could be a false negative in this setting. You showed data that generally tests come in about 90% in the upfront setting in terms of positivity. And so there's a chance 1 in 10 that this patient was not positive upfront. Nevertheless, in the overall context, it would be reassuring or add to the probability that this patient does not have radiologic evidence of disease at this time point. But I would not use that for any decision making for the reasons stated.
Yeah, so let's talk about some of the reasons that this single data point is problematic, and you hit on this obviously. So first of all, this patient may or may not have had a detectable level pre-treatment. We do not have a pre-treatment level. So for example, perhaps they're a genotype that is not part of the panel that was used to test this patient. Or perhaps they had a tumor that has low level shedding of ctDNA, so the level of detection was below the assay's threshold. You can have other technical issues, like you can see mutations that actually disrupt the ability of the primer to bind and other sort of technical issues. But this patient, we do not know if they had a pre-treatment detectable level is the important part. And so making assumptions that a negative level post-treatment is very, very confusing. The other thing is that this could just be a false negative, right? We do not know if this is a true negative or a false negative. And by false negative, I mean below the level of detection of the assay that's being used to detect it. And so the take-home message from this first slide is exactly what Dave said, which is that for recurrence monitoring, longitudinal data is really critical. It's very hard to interpret single time points. And it's especially hard to interpret time points. And I would caution people not to interpret time points in which you do not have a pre-treatment level to begin with. Okay, so here's our next graph, a little bit smaller, I apologize, but it's a patient who also had surgery. You can see their levels clearing 1 day after surgery. By the way, these are all patients, these are all real patients treated at Mass Eye and Ear and having their levels followed on our internal assay. And you're going to see lots of false negatives and stuff. So just you're aware, this is actually all real data. So they clear after surgery and they stay 0 until 130 days after surgery. So this is their graph. So same question, how do you interpret this graph now?
So in terms of this graph, it's a little bit different of a situation. So let's say that it's most likely there's the highest chance that you were testing for HPV type 16. It was positive. It looks like it was about 180 to 200 copies per ml. This is a 62-year-old T2N1. And I guess you're saying that they didn't have any adjuvant therapy. Maybe they did, but regardless of their treatment, they're going to be at fairly low risk for recurrence. And I think that this negative testing along the way adds to the likelihood or probability that this patient doesn't have disease. And it makes me more confident that there's not active disease that is being missed. So I think there is more validity in using the surveillance time point here than in the prior example.
So what's the diagnostic accuracy in MRD in the MRD setting after surgery using a ddPCR based approach? And with what certainty can we say that negative levels after surgery represent no residual disease, negative MRD? It's open to anyone to comment on, and there may or may not be an actual answer. It's just yeah.
What I can say is that we have high negative predictive value of these assays, right? I think I would probably take an opposite position of panelists to say that I don't know that any of this is reassuring, because I don't think we have real data on any of this. And I think the first example would, to me, is just totally meaningless. And even this would be great in a research study. But clinically, what to make of this, I wouldn't know. I think we can read a graph and we can say, that the copies per ml are 0. And we can, put it in the context of data that we have that has significant limitations. And I think, unfortunately, we're at a place in the field where we don't know what the performance characteristics are. And it depends on the assay, it depends on the sampling, and how often you do it, right? So all of that influences the performance characteristics of what we're talking about. The other thing I'd point out in terms of context for the data is, type-specific infection matters. I think you had put genotype on the previous slide, and I don't know that we've talked about it, but making sure that it's same as what's in the tumor, and when you're looking at the copy numbers.
I would agree for MRD. I don't think that we have an idea. I think it's assay dependent, and that we don't have a lot of orthogonal testing to say what is the limit of detection, and even if we have different limits of detection, what does that mean in context? So we need a lot more data in this space, and I would am a little bit more inclined to say we have better surveillance data in the MRD space. We need a lot more data.
Yes, this is data that I showed earlier from my group, right? I showed that patients who have low risk disease, who have surgery and go on to observation, they clear early, and patients who have macroscopic residual disease stay elevated. But what I didn't show you were patients like this. These are patients who have surgery and then got adjuvant radiation. And so these are patients who then all have classic risk factors for residual disease because they're getting radiation. And you'll see there's a whole bunch who clear. And now we don't know if these patients are clearing because they have no residual disease and we're overtreating them with radiation, or if they're clearing and they're just below the threshold of the test, and they would have recurred if they hadn't got radiation, right? So it's very hard to study this because many of these patients are getting treated, and you were not going to observe all of these patients because it wouldn't be acceptable. So it's a very hard thing to study, and the answer is we don't really know yet what the predictive value in the MRD setting is. So here's the question for the audience, and I think JJ is controlling the audience poll. Do you guys think that this should change the treatment plan? So for example, I mean, if this patient had risk factors for residual disease and they should get radiation, let's say they had 6 nodes positive, a no E&E, at my institution, they would get radiation, let's say. Do people think that based on this graph, we should forego radiation and just observe because they have negative ctHPV DNA levels?
Okay, people are responding. We'll close it down in 5 seconds. Okay, and here are the results.
So 20% say yes, forego adjuvant radiation based on this, and 81% say no, do not change your treatment plan based on this. So here's the rest of this patient's graph. Okay, you can see that they actually have a recurrence, or what I would call persistence, within a year of their original treatment. They did not have adjuvant treatment. They didn't actually qualify for adjuvant treatment. You can see here their clinical detection of recurrence. It was in the neck. They had a neck dissection and clearance again. So what are some reasons? So we now know that these are false positives by definition. This patient has a recurrence. So what are some reasons that these could be false positives? Can people just throw out some
False negatives.
false negatives? Excuse me, false negatives. Thank you. If not, I'll throw them out. So they can simply be below the detection threshold of the assay. And this is a very important point, is that all tests have thresholds below which they're negative, but it's a true positive. So it's a critically important point that 0 doesn't mean no residual disease. It means potentially below the level of detection of the assay. What are other reasons? The sample could have low total cell-free DNA, and that can be for a number of different reasons, including a low blood draw volume, for example, not a lot of blood collected from the patient. And there can be a technical error. So technical errors happen in the lab. These include human errors like pipetting errors or machine errors, or it can be a platform error. You can have a false negative because there's a technical problem. So this is really important to keep in mind. This doesn't really happen with CT scans. A CT scan is a CT scan. You know if there's a motion artifact, for example, but you can see the result. The false negatives for technical reasons in molecular setting are much more difficult to understand as the reading clinician.
Can we go back to your question with the poll for MRD a little bit?
Yeah.
So one comment there is it may be the patients that are MRD negative actually benefit from adjuvant treatment more. In some disease contexts, it turns out that if you have MRD positivity, that's a signal that you may be more likely to recur distantly. And so that local control is even more important. And we really don't have a good idea about the limit of detection that we are looking at. And so outside of the context of a study, I think on study with consent, as we talked about, is a different story, but would really advise caution about adjuvant decision making in the context of a negative test.
Yeah, I agree completely. I think people have to be very careful about changing treatment decision making, and this graph is just one example of that. I don't think it's appropriate, frankly, to omit guideline-based treatment based on the results of a liquid biopsy at this point in time. We just do not have enough data to do that, and I'm happy to have people disagree with me if they feel differently. And there's another important point here, which is that different assays and different platforms will have different limits of detection. So this is a nice paper from Chad Brenner's group at Michigan that is either about to come out or just came out in oral oncology, looking at comparing a multiplex assay that they built to a commercial assay, looking at the same patients, same blood specimens, showing significantly different performance metrics. And this is just to show that the same sample can give you different answers using different assays. Okay, this is data from my lab, running the same patient, same blood sample on two different assays in my lab. In blue is ddPCR-based assay, in red is an NGS-based assay. The patient's getting chemoradiotherapy. You can see this patient clears their levels on ddPCR after treatment. They do not clear their levels in NGS. They still have residual disease. We're only seeing it on one assay, a more sensitive assay. So it's important to recognize that different assays perform differently. So false negatives are very common with the current approaches due to limits in sensitivity, especially in the MRD setting. So I think people have to be very careful about changing treatments like we were just saying. So here's another audience poll question. Have you ever had a patient who had a negative ctDNA after surgery and then refused standard of care adjuvant treatment? So they were supposed to get radiation based on tumor board recommendations and NCCN guidelines. They had a ctDNA level that came back negative, and the patient says, you know what? Assay says I'm negative, I don't want treatment.
Right. Closing the poll in 5 seconds. Okay, and here are the results.
Yeah. So about 30% of people say, yes, this is happening to them. And the reason I put this in is because I've heard this a bunch from people that this is happening. And I think it's very problematic because patients don't necessarily understand these limitations that we're talking about today, that a negative assay doesn't mean no residual disease. And so it raises some real ethical issues. And so, I guess I'll open this up to maybe Andy or Chiara, like, wow, when we think about what the impact of false negatives are on patients and their understanding of this, how do you think about that?
Well, can I go first, Andy?
Yes,
Yes. So, when you were discussing, I was wondering. Liquid biopsy results have clearly an interpretative issues, and I was wondering what of these concerns can a patient really understand and appreciate. I'm afraid that patient cannot grasp the real problem here. They may not comprehend statistic reports or may not apply these reports to themselves in an objective manner. Cherry-picking information, for example, concerning the incidence of false positive and false negatives is a real issue. And so I might sound redundant in here, but I think that patient information is central, and it requires time for physicians and also training for physicians, because it's really hard to explain and to let patients really understand the point here.
I agree completely with Chiara. The only thing I'll add here is I am also worried about inconsistency in how these are interpreted and applied depending upon the setting, what a patient may look like or where they're from or what their insurance is or their background or understanding of their own capacity to understand this information, but also from the clinician. Different clinicians in different settings may have very different thresholds for what would lead one to change practice, either evidence-based practice or more in the gray zone. And I worry that is also going to beget both making it impossible to interpret the data because different people will do different things with the same information, but also potentially make disparities in care even more apparent for patients who are being treated differently for other variables that are very hard to quantify or understand.
So you touched a bit on my last point, so I'm gonna move on because we have a number of slides and we're running short on time. To move on to some the next case series, which is talking about positive tests. There we're talking about negative tests and false negative tests. We're gonna talk a bit about positive tests now. So Dave, I like going to you. How do you interpret this graph? This is a patient treated with surgery. Their level's clear after surgery, and it looks at about day 220, let's say, or sorry, 250, let's say, there's an elevated time point.
So one thing I would say is that I don't know what test you're using. I don't know any of the characteristics of this test. The copies that you're showing on this graph are looking like they're in the 2 to 3 range, copies per ml. And I don't know whether that is likely to be a false positive or a true positive. And so a lot of that
assay positive.
It's assay positive. Okay.
This is a test positive. Yes.
So this is a test positive. So I would say that there is a high probability, depending on the assay, that this patient has some evidence of disease that is recurrence. Now, whether or not we should be testing or doing anything about it is a different question. I'm just talking about based on what we're seeing on the assay here.
Okay, so next audience poll, what would you do next? JJ, do you mind executing on that? Thank you.
And while that's going, we're getting some good questions in the chat, looking at the role of imaging in surveillance. What evidence do we have for that? And how does that compare to surveillance methods otherwise? And why should we use any testing outside of level 1 evidence?
Okay, closing the poll.
Great. Yeah, and I think we can come back to those at the end for sure.
And here are the results.
So 62% of people say they'll get imaging. 3% wouldn't do anything differently. 36% would repeat in a few weeks. Okay. So how do you talk to patients about this? You know, what do you tell patients when a ctDNA assay comes back and it was previously negative and now it's positive and they have no evidence of disease currently that you can see? And by the way, the patients, of course, can see the results, right? So they see this result before you saw it. Dave?
But I think the most important thing is that you have had a conversation for any test that you're ordering with the patient up front to talk to them about the risks and the benefits of even pursuing a test, any test in the setting of HPV associated disease or otherwise, about what a positive or negative result may mean, whether or not they want that test, and why you may pursue it in terms of the benefits and the risks. I will say that in radiation oncology, since the 1980s at Mayo, we've been ordering PSAs in surveillance for patients with prostate cancer. And so there are thousands of men that we end up seeing that have a positive PSA, and even with a PSMA PET scan or other targeted PET, have no evidence of disease radiologically that we can find. And we have a lot of experience in counseling those patients, managing expectations, and talking about what that may mean. So it is a conversation that we have a lot clinically, but that's in a setting with a lot more evidence regarding next steps in management. So I think the most important thing here is the conversation that you had before ordering the test, and also talking about what you would do in this situation with the patient if it became positive as the next step.
If I can just point out that one of the pitfalls of this whole strategy at this point is that we don't know the meaning of one test versus two tests. And in the literature, performance characteristics do change if you look at it as a standalone test versus, two positives. So doing them sequentially. And so I think that's an issue in terms of what we tell patients and what this means, because we don't really have reliable data to fall back on. The other part of it is that, while we might be suspicious of microscopic disease, we don't have a good way of diagnosing it at this point. And so are we just giving people additional stress and anxiety when they could just be living their life? And about half, in most of the studies don't go on to develop a recurrence, a clinical recurrence, I should say. And so, that's again, assay driven, but based on what's in the literature thus far, this is not 100% if you're positive on whichever assay, that a patient will go on to develop clinical recurrence. So I think it muddies the water. And I always use the example of unknown primaries when we know someone has regional MET and we can't find the primary. And so, this is kind of an analogous situation if it's low burden of disease. The other thing is in terms of copy number, are we looking at local, regional, or distant metastatic disease? We don't have categories. And so if you look at a very validated clinical assay that has rolled out recently, the rapid troponins, they understand the dynamics of it. They understand what the cutoffs mean. And they did this using huge sample sizes. And it's been, validated in laboratories around the country. And so I would just say that I wouldn't know how to really counsel a patient. I think I've learned kind of by we initially did this, and then we realized that we might be doing more harm than good. And so we paused on it clinically at Hopkins, at least most of us, as that did in the group. So that's my bias.
All right, so here's the rest of this patient's graph, goes back down the next time. And so how would you explain this? Who has a theory for what's going on here? What are some reasons you could see an elevation then a reclearance? Maybe in the interest of time, I'll tell you what I think. So one, you can have sample contamination. There can be a problem in the lab with contamination. It's very easy to have happen. It happens in clinical CLIA labs. It happens in research labs. It happens all the time. You can have what I'm calling stochastic noise. You can just have a false positive because of the way the platforms work. Or there could be something else biologically happening here, like immunologic clearance, like the patient's actually having a micro recurrence that then's being cleared immunologically, and that just throwing it out there is an interesting hypothesis when we see these little blips as a potential phenomenon that's occurring.
Can I throw out another reason? That person could have some anal dysplasia, right? So there could be something else that's going on that would explain it. The other thing I'll add is from the anogenital natural history of HPV, they weren't using as sensitive methods, right? It was just based on RT-PCR. But you saw this, these blips where it would go above and below the threshold of detection in all the long-term natural history studies. So I think that's the other possibility.
So I think a good point here that Dave mentioned earlier is that I think it's really critical to confirm elevating levels with a second test and look at the trend overall and be very wary of a single point in time is that I think an important take-home message. Here's a patient being treated with a number of different modalities across time, induction chemotherapy followed by consolidation chemoradiotherapy, they have a recurrence, they get chemoimmunotherapy. You see these levels here. I'm curious how people think about these levels here. They're sort of going from a negative test to a positive test to a negative test to a positive test. You know, what are people's thoughts on this? I'll tell you my thoughts. This is, you know, levels that are vacillating around the level of detection, like Carol was just mentioning, that it's probably not changes in actual tumor burden. It's just vacillating between positive and negative tests, right? The detection threshold, but with a low level of residual disease. And it's another point, another sort of example why single time points are very problematic, because this patient is negative in one time point, positive in the next, negative again. And so we'd be very careful about interpreting individual time points. You can see this patient eventually is taken off of chemotherapy and left on immunotherapy, and then they begin to progress.
I think it's important to understand that different types of treatment can impact ctDNA in different ways. If you look to the lung literature, patients that cleared ctDNA with immunotherapy had a greater pathologic complete response rate than patients that cleared ctDNA prior to surgery with chemotherapy. And so some of those monitoring levels are best done on study and with an intent behind it to impact treatment if you're going to do it, because otherwise I think it would be hard for any of us to take a signal out of the noise that we just saw.
How do people interpret this? These are patients being treated with, this patient being treated with surgery, doesn't clear, and then has a re-elevation. This is a patient being treated with chemoradiotherapy, eventually clears, re-elevation. How do people interpret what's going on at these time points where you're seeing elevations? What do you think this is? Is it an incomplete response of treatment? Is it recurrence? Is it something else?
I think the fundamental point is we don't know. And that's what, going back to Dr. Rahman's comments earlier, need to be shared, that we simply don't know how to interpret these. And the challenge in interpreting them in real time requires us to recognize to patients the inherent unknowns and lack of data to inform what we should be doing, just as Dr. Bakri brought up earlier.
So yeah, so I think that's a great point and great segue into what we now know is happening at these points in these two patients, which is that these are actually second primaries. These patients actually have second primary cancers. What we're detecting is their second primary in each setting. You can see the patient eventually goes on to be diagnosed with sinonasal cancer. In both cases, they originally had oropharynx cancers. And so I think it's very critical, just like Andy said, is that we don't really know what's going on yet in many of these situations, but it's important to think about other scenarios why levels may be elevating. If you see that, in this case, these are patients who have second primary cancers. This is not a recurrence of their primary cancer. With these assays, as they are right now, you really cannot tell between you cannot tell between a recurrence of your primary cancer and a second primary cancer.
And that second primary may not be a head and neck one, although you show one that's right.
Correct.
In places that we don't usually think about, which is, I think, another, issue with this assay. It could be, true, unrelated, different compartment.
Absolutely. So here's a patient being treated with chemoradiotherapy. I know we're going to wrap up soon. We're about 5 minutes over. We've got 1 or 2 slides left, I think. This is a patient being treated with chemoradiotherapy. Their levels downtrend, they never clear, and they start to re-elevate. So I think across multiple time points. So Dave, this is pretty obvious. How would you interpret this?
I think that's definitely concerning. I would use the contextual information that I have along with that. This is N3 disease, and our standard would have been to get imaging there at 90 days as well. So there could have been an indeterminate, or you see the imaging time points there.
They're negative.
The imaging was negative, and exam is negative as well.
That's correct.
And was that a PET CT that was done at both points in time?
They were both chest CTs and head and neck CTs, like no PET CTs.
No PET CTs. So, I would have to have the context of the discussion of why we were ordering the test and what we were using it for. In this context, I would be concerned that there's disease present that's not radiographically represented on the imaging that I have ordered.
So we addressed this a bit already. So this is an audience poll question. If the imaging was negative, as I just showed you, we had 2 negative imaging so far, what would you do next?
We will close the poll in 5 seconds. Okay, and here are the results.
So the most common answer being order repeat imaging in 3 months. People are very concerned. Obviously, there's something going on, follow standard guidelines. So here's the rest of this patient's graph. You can see their levels continue to trend up over the next over a year. They eventually present to the ED with a fracture of their hip. Here's their metastatic lesion in their hip, their HPV positive cancer metastatic to their hip. They eventually start treatment and levels start to trend down. So I think the take home message I'm trying to get across here is that continually elevating levels does have a very high positive predictive value for residual disease, but that residual disease may or may not be in the field of imaging for how you're looking, but you should have high index suspicion, obviously, if you're using these tests and the levels continue to trend up across time. So here, this being atypical or out of.
Can we use this though as an example of the harm that we can do? Because the person basically spent 300 days in stress probably and anxious, thinking of, oh, what are they going to find? Right? And probably didn't change anything because you couldn't find it. And so that's, minus 300 days of better quality of life, whatever the person's quality of life.
So this patient, because this is being run in my lab, is being run as a research assay, did not know this test result. But your point is that if this was a clinical test, had been ordered and was relayed to the patient, they would have had, actually, I believe the recurrence occurred, I think 700, 800 days later. So multiple years of being told their cancer was there, but wasn't identified, is what the point you're making. So I think it's a great, point. And, what do you think, David? It sounds like you have something to say.
Well, I think the data for surveillance are much stronger and a little bit different to me than the MRD setting. And what I would say is, in the context of a study, most especially for other disease sites, using prostate cancer again as example, we know that initiating therapy at a time point when there's less of a burden of disease results in better outcomes. And that's been shown by multiple studies. And I would say that there was probably radiographic evidence of disease that was present at those first 2 time points, had those been in the field of view of imaging.
But David, what evidence do we have to show that at this point? We don't have any evidence in head and neck cancer and HPV related disease that you have an earlier therapy to initiate. It would be great, right? The ideal that we're all working for and we all have trials for is if we can catch it early with ctDNA and get clearance before you develop clinical disease, right? But right now we don't have that, and we're talking about getting serial scans on someone and telling them you're at high risk of developing disease, right? So I think we all agree that's the vision and that's what we hope, but we're just not there yet.
Right. I'm talking about in the context of a study here, that if this patient were on a study, then we can influence what the ideal timing of imaging may be, or we can see if reflexing to a PET CT would be helpful for catching disease earlier. But we don't know if that catching disease earlier leads to better outcomes or not.
Exactly.
But I think we're in agreement that we need to determine.
We do it on a study.
So while
Totally.
while I was defending this graph, since I made the graph and I did data that this was a
You gave us a topic of conversation, Dan.
and the patient didn't know in this setting, this is happening clinically, right, all the time, and so it is a relevant question, like you're saying. So absolutely. So I believe this is my last slide. So I think, David, I think you kind of addressed this already a bit, that at Mayo Clinic, you guys have a lot of experience using other biomarkers where you find yourself in this scenario. I think the reason I'm putting this here is that I think a lot of head and neck surgeons, for example, don't have a lot of experience talking about molecular detection of disease and recurrence and not having imaging correlates and what you do. And I'm not sure that everyone routinely, for example, talks in great detail to their patients ahead of time about the performance metrics of the tests and what a positive or negative can mean. That, it sounds like you guys take great care to do that in your practice. And so I think that's why I put this here, because I'm not sure that always happens. And I'm curious to hear what the other, clinicians, think about that.
My message is probably different than you guys.
So this is exactly what you guys were talking about. And this is where it really boils down to the monitoring setting, right? Which is there data to support benefit from earlier recurrence detection? So yes, these assays do detect recurrences earlier than imaging, it seems like, from what we can tell. With lead times on average, I showed about 3 to 4 months. Because if you look at an average time span, I just showed a patient with a lead time of like almost 2 years, but an average, we're talking about days to months. So the question is there benefit to that at this point in time?
I mean, we already have data from pets showing that not really, right? That survival doesn't improve when you necessarily detect something early. And now with new treatment and immunotherapy, perhaps that may change, but we'll only know that with trials. I think using these molecular tests to do so is the holy grail, as Dr. Proctor just brought up. That is the seductive component of this. We absolutely want to be able to detect these early and catch them early and treat them early, but we simply need to do the research trials to actually show if this is predictive and what we can do about it in a way that actually engenders change for our patients.
So in light of this, that we actually don't have data to support a benefit to patients in detecting recurrence earlier, and perhaps actually doing harm by giving them increased anxiety about the fact that their cancer is going to come back, but there's nothing that can be done right now, potentially, just saying. How do we, this is an open-ended question, how do we justify to patients potentially having to pay out of pocket for serial monitoring ctDNA assays if we can't tell them there's an actual benefit to them? And I'm curious what you guys think about that statement. It's the most provocative question.
Difficult.
I'm sorry?
I think it's very difficult. I think it's challenging to do that. I think we can probably all agree, if we're doing this, already clinically, or if we do on trial, there is reassurance for the patient and for the doctor at some level and the family of a negative assay. That we get into trouble with the positive ones, and how often do you do it, right? So how often is it justifiable to have a patient pay out of pocket for this? So I would say it's very challenging to do that, and we're not in a place clinically to justify it.
Okay, so to wrap up, some of the sort of practical questions from my perspective, or practical take-home message from my perspective, that ctDNA testing is generally not helpful without a pre-treatment level and without trends across time. That existing approaches have real limitations in terms of minimal residual disease detection. That's a critical thing to understand. The performance metrics of different tests can vary between assays. Positive tests that are confirmed with a follow-up test have a very high specificity for having residual disease. What you do with that, though, is very complicated, and whether it's a benefit to patients remains to be determined. And so I think some real needs in our field right now are that we need guidelines on how to interpret results, and how to make decisions based on those results in an evidence-based fashion, and how they fit, and understand how they fit into existing guidelines like NCCN. And of course, we need prospective trials to ask these questions in the right way. And a number of those are going on, including trials being led by David, for example. And so I think those will be really informative in the coming years as they start to read out. So with that, I want to thank the AHNS. I want to thank all of my co-moderator, Andy, and the panelists. I want to thank my lab, who generated the data we looked at today and made all the figures for today. And if people are still around, we can take some questions. And I don't know if people David, if you were taking some chats, or we have some stuff here.
Yeah, we have a lot of questions in the chat. I don't know if there's time to go through them.
Why don't we go for 4 more minutes to 8:20, and we'll take 1 or 2. Do you want to pick one that seems intriguing to you?
Yeah, I'll ask it to the rest of you, which is one of the questions is about what we should do in terms of imaging. And, you know, we have data now that's looking at a very high positive predictive value and a very high negative predictive value in surveillance by multiple different groups, commercially or not. And do we really have the same data at a high level for PET CT or other imaging modalities? So how can we favor one follow-up test over another, given the current data that we have? What's the evidence for imaging surveillance that we have, or for laryngoscopy?
So I think Andy alluded to the fact that there's very poor data to support imaging in the monitoring setting, which is why there's not a standardized approach that's recommended currently. So I think that that's clear to everyone, and is reflected in the variability from institution to institution of what monitoring looks like. And I think is made further complicated by the fact that there is been shown variable or low benefit to obtaining imaging in the monitoring setting, which really distills down to the fact that we don't have I shouldn't say that, our salvage therapies are less effective than when we would like them to be. And so it does beg the question of are you doing good or doing harm by doing intensive monitoring? And that it goes for whether it's blood-based or imaging-based. And so I'll stop there, but.
I mean, what our hope is that we catch it earlier when salvage is less morbid, right? But before all this, there was even a question of what the surveillance should be among HPV positive patients who generally have good survival, right? And decreased recurrence. So I think that's the other thing that we have to think about, is the natural history of this disease and what direction we're already going in. And that may actually be a place, once we study it, that with high negative predictive value, those are the people who we can reduce surveillance in. But again, we don't know duration, frequency of testing, and predictive value. So we'll figure all that out.
Another elephant in the room, just to say it out loud, is that the vast majority of what we do in head and neck cancer is not driven by level 1 data, right? We make decisions in the gray zone all of the time. And we're not privileged to be cardiologists who have 1 million patients to put on RCTs to inform everything that we do. So one of the challenges for us is the fact that we are so comfortable making decisions based on imperfect data that we don't want to continue to do so with a new test that's unproven, that brings up additional layers of complexity and potential harm, simply because we're so comfortable operating in that zone where we don't have a great answer.
And most of the patients come to us, right, with their recurrence, rather than us finding them in our usual clinical surveillance, right? That's the other wrinkle in all of this.
So I haven't had a chance to scan through all the chat comments, but I don't know, Dave, if there's any other that are jumping out as you as things you want to, or anyone else that you want to address. Otherwise, we'll wrap up. Already 20 minutes over.
Bruce Hoey has a nice comment at the end in terms of, is this an exercise in futility? Because survival is already pretty good, so, and salvage works. So is early detection valuable? That's the point he's making.
Great. Well, with that, I think we'll conclude. So thank you to everyone for joining. It was a great showing. It was a really interesting discussion, a really important topic. I think there's more unanswered questions than answers, which is why it's important to talk about it. And I want to thank all the panelists and my co-moderator and everyone for contributing. So thank you and have a great night.